Good afternoon, ladies and gentlemen. My name is Chris Wilson. I'm the Communications Director here at the Dallas-Fort Worth Hospital Council. The webinar is beginning. Steve Love, our President and CEO, is normally the host of our webinar series. He was called to Austin and had to fly to Austin this morning, so he sends his apologies, and I will serve as host today. Thank you for being here today for this webinar. We're hosting it in coordination with PYA-PC, an associate member of the council. PYA was built on the principles of outstanding client service and exceptional advice. Since 1983, PYA is consistently ranked among the top 20 healthcare consulting firms in the U.S. and is a top 15 auditor of the nation's largest health systems. Today's topic is, are you ready? Compliance with new price transparency requirements for hospitals. As detailed in the 2024 Hospital Outpatient Prospective Payment System Final Rule, hospitals are required to make significant changes to the posting of their machine-readable price transparency files. While some of these requirements were effective in January, most of the changes are required as of July 1st, 2024. This session will address those requirements as well as numerous insights from questions posed to CMS regarding the complexity of compliance with these requirements. Our speaker today is Kathy Reep, a Senior Manager of Consulting and Business Development at PYA. I believe Kathy's done an additional webinar for us too in past years. She has more than 3 decades of experience in healthcare with expertise in compliance, financial advisory, reimbursement, and managed care. Kathy has helped clients with Medicare, Medicaid, workers' compensation, reimbursement, and many other complex programs. We have a great turnout today, and we are looking forward to her presentation. Before we begin, please note we will be taking your questions. If you could type them in the Q&A or chat box, we'll answer them before the end of the webinar. And with that, ladies and gentlemen, here's Kathy Reep.
Thanks, Chris. I do appreciate the opportunity to have some dialogue with y'all today as it relates to the new transparency requirements. Chris, I would be glad to take questions as we go along if you see them in the chat. Just because I think it's a great way to make sure I address the issues that are pressing at that moment. I do know that earlier this year, a couple of months ago, I believe, DFWHC had a webinar presented by staff from hospital pricing specialists that related to the new price transparency rules. And so I wanted to touch base on some of the information might be a repeat of what you had, but we do have some more newer information as well because of questions that have been posed by providers into CMS and the responses that have been posted. So I'm going to share with you information, literally how you can follow those questions that are being asked and perhaps even ask some of your own as we go through. So let's go ahead and get started. There we go. I think one of the things that we need to be looking at is just a bit of a reminder, and this is a two-part reminder. One is about what are the requirements and currently as it relates to price transparency. And secondly, I've got to remind you that all of this requirement that you are doing from a price transparency perspective is as the result of an executive order that was issued during the Trump administration. It was then followed, that executive order was then followed by regulations that were included in the November 2019 Federal Register related to outpatient PPS. And so we do not have legislation that requires the compliance with price transparency. This is strictly as the result of an executive order. Also recognize that Congress has been looking at the issue of price transparency and has actually raised the issue of implementing legislation to require you to be compliant. When they have done during this past session, although it was not passed late last year, they passed the House, did not pass the Senate, or actually didn't get heard by the Senate. It was actually even looking at increasing the penalties on hospitals. So recognize that this continues to be an issue in Washington as it relates to hospital compliance and actually codifying the requirements for price transparency. Compliance was originally required as of January 1, 2021, and there were two parts to that requirement. First of all, that you post a machine readable file, an MRF, and that machine readable file was to include all of the items and services that you have in your charge master. And for each of those items, you were to include your actual gross charge. And although my slide says charge on all of these elements, recognize that that is what is used in the regulation. We know that payers do not have charges. They don't negotiate charges. What they negotiate is rates. So you are to report your gross charge, your payer-specific negotiated charge or rate, for each of your various payers and products within an individual payer. So your payers and your plans. And then your de-identified minimum negotiated charge, your de-identified maximum charge, and your discounted cash price if you have one. The other part of the requirements that were in place as of January 2021 was that you also post a consumer-friendly listing of your standard charges, up to 300 shoppable services. 70 of those shoppable services were provided by CMS. And then if you provided another 230 distinct shoppable services, you were also required to post that information. If you did not provide all of those 70 or another 230, you were to provide whatever you had but shoppable services. People do not shop for an emergency room level 5 service. They will shop for a chest x-ray or CT scan perhaps, but make sure that that list of consumer-friendly items are shoppable services. We have always had the requirement, but both of these files were to be updated at least annually, showing the date of the last update. And we were allowed to, for the shoppable services, post a price estimate, or use a price estimator tool, something that would actually be consumer friendly, something that they would use perhaps to truly look at what do I owe, not what have you negotiated with my payer, but what do I owe? And a lot of hospitals, in lieu of the shoppable services, used a price estimator. In the legislation that was addressed by Congress earlier this year, or late last year again, they were looking at allowing you to maintain a price estimator, but not in lieu of the shoppable services. So we will see if that comes up again later this year or into the next year. In the outpatient proposed rule that came out in 2023 for 2024, CMS made considerable changes to the requirements as that relates to the machine readable file. They did not address the shoppable services. This is strictly only the machine readable file. We're going to walk through the requirements that CMS is now imposing on providers and their postings. And we're also going to talk about some of the enforcement changes that CMS has made for going forward beginning in 2024. So all of the new requirements that are out there and available can be clearly identified, reviewed, looked at. What do you mean by going to a website that CMS has posted? It is a GitHub site. I've given you the link on this slide, and it truly walks you through in great detail all the various formats, all of the various elements, how you determine the information on these elements. And they have also included within the GitHub site an opportunity for discussions and for you to pose questions and for CMS to respond to those. So we're going to walk through some of those questions that have been posed as we go through today. The first requirement, or the first series of requirements that were required as of January 1 of this year. First of all, and this has pretty much been in place since the beginning, although you weren't truly required to encode your information historically, but that hospitals make a good faith effort to ensure that their information in your machine readable file is truly accurate and complete as of the date of that machine readable file. That was your number one requirement. There are two other requirements that were a little bit more involved, I think, and required some steps on the part of the provider as of January 1. The first one was that you include at least on the footer to your homepage, to your website, could be elsewhere, but it must be on the footer to the homepage, the words price transparency. And when you click on price transparency, that is going to take you to your machine readable file and information about your rates and charges, so that you do need to make sure that you do have that price transparency label in your footer on your homepage, and that it takes you to the machine readable file. That is a requirement as of right now. The other requirement, and I'm going to show you graphically how this works and how you actually complete it, is that you have a TXT file at the that hosts your machine readable file. It basically provides people with the information as to where your machine readable file is located, as well as who is the contact for your machine readable file if there are questions, and what is that person's email address. So in order to get that TXT file, again, you're going to go into the transparency, the GitHub, and under the transparency tools, you are going to be able to go in. I've again given you the TXT generator webpage on this slide. If you put in the cms.gov github.io hpt-tool TXT generator, you're going to get what I've shown here. And you're basically going to fill out this information. What is your hospital location name, the name of your hospital, your source page URL, and where is your machine readable file, who is your point of contact, and who is that point of contact's, what is that point of contact's email address. Recognize that on that point of contact, if there are any issues or concerns with your file, this is who CMS will be contacting. It is very important that you keep this current and make sure that if that point of contact leaves, that there is that this file is updated. We actually had one hospital across the country who was penalized for non-compliance. Letters were sent to the CFO. The CFO had left, and the interim CFO did not get those letters. They did not get the communication, and therefore the hospital was fined for non-compliance. So recognize that whoever you are putting here as the point of contact, and that contact information is maintained and is updated. If you fill out this TXT file generator, what you're going to get is information that looks like this. It's going to be the hospital name. Now, the reason I've given you two examples here is because you could be a hospital with multiple campuses. So you have General Hospital North and you have General Hospital South. But recognize that you would do this for each of your locations and that you would create this file for each of your locations. You can see that Hospital 1, their standard charges file is using a comma separated values, a CSV format. That is right here in this field. And Hospital 2 is using standard charges in a JSON schema. Those were the only two formats that CMS is going to allow in this new process. CSV, you can actually have a wide or tall format. We'll show you examples of that. And then the JSON is a single format that you're going to use. Many providers in the past used essentially an Excel file that they posted. That's no longer going to be allowed. There have been questions that have been raised with CMS. Can we just post this? And CMS has come back and said, no, the rules say CSV or JSON. So are you ready for July 1st? I'm assuming that those requirements about having made a good faith effort, you did, that you have that TXT file and that you have price transparency in your footer. Now let's look at what you're required to do by July 1 of this year. First of all of the information in the defined formats that CMS has identified, the CSV wide, the CSV tall, or the JSON schema, are to be encoded. This is encoded information. Again, I will show you what it looks like and what it looks like if you actually look at the consumer view. You are to encode your hospital name, your license number, the location of the hospital or locations if you have multiple campuses, as well as the addresses of those facilities. All of that information is in your header, along with the date of the most recent update. That is also encoded in your file. So if someone actually wanted to go through and look at every hospital and see if they were, if their files were up to date, having a limited way to post this information and having it encoded would be much simpler for a quick review. You are also to, for all of your charge information, think about all the line items that you have in your charge master, as well as your DRGs, your outpatient services and the like. For each of those items that you have listed, you are to first of all identify the location or setting for those services. Are these charges that are inpatient charges? Are they outpatient? Are they both? And in some instances, you could actually have a provider, certain services, you could say, this is, let's just use your emergency room charge. That is an outpatient charge. But if you have a lab service, that could be either inpatient or outpatient. And there are some providers who have more of a reference lab and the charges are less at that particular location than they are at the inpatient setting. So that's where you're going to be clearly delineating inpatient, outpatient, or both for all of the items and services that you have listed in your charge master. For all of the items as well, you have a lot of codes that you're going to need to enter. If it is a, let's say, for instance, it is a lab service, you're going to have to identify the HCPCS code that goes along with that lab service. If it, same thing would be if it is a radiology service and it's provided on an outpatient basis, you're going to be identifying those codes. You're going to be identifying DRGs, APCs, national drug codes. You're also going to be identifying for all of the various components that you would normally associate with a particular service. You're going to be identifying, let's say as an example, that, and I'm going to use outpatient observation as an example. Outpatient observation is an outpatient service. It is billed with a particular revenue code 762. And so you're going to identify outpatient observation 762. And my code descriptor is going to be an RC for revenue code. So a lot more detail than you have ever posted in the past as it relates to all the items and services that you provide. You're going to have to identify all of your payers and plans as separate data elements. So you're going to have Blue Cross, but then you have multiple products under Blue Cross. You're going to have to clearly delineate each one of those. The only time that you can actually lump things together is if you have a multiple PPO, multiple products where you have of a like type. In the example I've given you here, it's PPO. If you have multiple products with the same negotiated rate, you can lump those together under an individual payer. Also, you're going to have to, and this gets a little bit more difficult because for each of your charges, is this a dollar amount? You're going to have to clearly identify that it's a dollar amount. Is it based upon a fee schedule? I mean, have you negotiated to pay you $5 or have you negotiated to pay 50% of $10? So you're clearly going to have to identify the methodology upon which your negotiated rates have been set. A flat amount, is it a fee schedule? Is it a per diem? Is it a percentage? Is it some sort of an algorithm? And by algorithm, I mean, is it something along the lines of a flat amount with a stop loss or a cost outlier provision? I think if you look at a lot of your DRGs, you have a flat rate that you can calculate for your facility, but then you are also going to have the potential for a DRG to become a cost outlier, and therefore it becomes an algorithm. There is additional reporting that you're going to have to do as of January of next year if you're looking at an algorithm in terms of actually going back and doing some historical calculations, but get to that in a minute. If it is a percentage, what we've had issues with in the past is that a provider has posted, let's say the charge was $100 and they have put 80 in the rate field. Well, is $80 a percent or is $80 the rate that's been negotiated? So moving forward, you're going to have to indicate that your negotiated rate is a percentage, and the percentage is 80%, and the calculation gives you this number. So you're actually going to have to go into a little bit more detail on all of the various contracts that you have and how your rates were negotiated and the methodology on which those rates are based. It's a lot of information that is going to have to be reported between now and July 1. And here's where I get into a concern in terms of the actual reporting of this information. Included as a requirement for July 1, 2024 is a compliance statement. And the compliance statement, as you can see on the slide, says, to the best of its knowledge and belief, this hospital has included all applicable standard charge information in accordance with the requirements of 45 CFR 180.50, and the information encoded in this machine readable file is true, accurate, and complete as of the date indicated in this file. When you are loading this information, you're actually then going to be able to enter a value of either true or false. Well, obviously you don't want to hit false because you're saying this is not true and accurate information. You're going to want to hit true, but who is going to say true? Is this something that is being done by an outside vendor who's posting your file for you? Is it going to be something done by internal IT? Or is this going to come about as a result of a group review, perhaps involving revenue cycle, compliance, IT, that outside vendor, managed care, others within your team, taking a look, spot checking this information and making sure that you agree that it is true and accurate? If you identify true and it is not, if there are errors identified in the file, this could have the potential for a false claim because you are claiming that it is true and accurate information, but it is not. And I'm going to just let you know that as an example, there is a provider, a matter of fact, here in Florida, who under the original files posted a payment, actually a gross charge for a 12 lead EKG of $48,000 plus. I guarantee you no one has negotiated, no one has a gross charge of $48,000 for a 12 lead EKG. This was an input error. It was a typo. But if they truly charged that information, it would have been covered in the news. There would have been massive patient complaints, etc. It was an error in their file. But when you're actually going in and you're examining the data that is in the file, and something that we at PYA have done a lot, taking a look at this information, if you have actually done something, have an error like that, you really don't want to have certified that it is complete and accurate. It might be just saying, let's do a quick look at all of the charges that have been entered that are in excess of $10,000. Do these look accurate? If you have negotiated a contract significantly in excess of your charge, if that's what's been posted in your file, take a look, verify that. Make sure that you have captured all of your products, plans and products. Make sure that all of your services are also identified in this particular file. That was as of July 1 of 2024. The next date we have to look at is January 1 of 2025. And again, a little bit more work on your part. Now, if you want to do this as of July 1, you can do it, but it is not required until, if you want to do it as of July 1, you can, but it is not required until January 1. First of all, for whenever you have you have negotiated a rate based upon a percentage or an algorithm, you're going to have to go back and provide the estimated allowed amount. What have you historically been paid for that service? And I will show you in a few minutes CMS's response to how do I calculate this. But you're going to have to go back in, let's say, for instance, with a DRG, it is truly, you have the potential for cost outlier provision. Then you're going to go back and you're going to report what have I historically been paid for that service, an average amount, as opposed to just reporting your normal negotiated rate without the potential for the cost outlier. For your drugs, you will have already reported as of July 1 the national drug codes for all of your drugs that you have within your charge master, but you are also going to have to, by January 1, report both units and types of measurements for all of those pharmacy items. And last but not least, for January of 2025, if there is a modifier that impacts your standard charge, if the modifier impacts what you charge for the service, then you're going to have to include the modifiers in your file, as well as a description of the modifier and how it's going to change your standard charge. Most of the, as an example, left-right modifiers are not going to impact the actual charge, but there could be some modifiers that do indicate, impact your charges, and you're going to have to include that in the information that you report as of January 1. Just very quickly, a couple of slides, because CMS did provide these tables as a part of the final rule, going through and being very clear about what information you are going to have to provide for your file, and including with this the effective date for these requirements. You can see that your hospital name, location, address, licensure information, that's required as of July 1. All of your payment methodologies, payment rates and methodologies are required. That estimated allowed amount isn't until January of 2025. Your description of services, your settings, that is as of July 1. Your billing and accounting codes, those are going to be your revenue codes, your DRGs, etc. And then your code types, those again are going to have to be clearly coded and identified by July 1. And I had mentioned the affirmation in the machine readable file. That's a July 1 requirement. The other requirements on this slide are hopefully things you were already compliant with as of January this year. Now let's take a look at what the files are actually going to look like. The first slide I'm showing you actually came from a webinar that CMS did in January. I believe CMS has actually learned a lot more information because they have they are updating on a fairly frequent basis some of the instructions related to the formats based upon questions that are asked by providers. But it just looking initially at their initial version of posting this information, and this is using a comma separated values or a CSV format. You can see that you get into a lot of detailed way to provide this information. Hospital underscore name, comma, last underscore updated underscore on. All of that is a part of the actual file that you are posting. And then with that, you are identifying West Mercy Hospital, your date, and the date is in the format that it is provided here. The version, in case you did not know, for everyone, this will be version 2.0.0 until CMS decides to change something else. One thing that CMS shared recently on a webinar was that an individual provider had posted hospital space name. They did not include that underscore. Their file did not get through the system because it was an error. And they didn't look at the rest of the file either because there was an error on that first line of the file, actually on the first item on the file. So CMS in their review of the file stops right there. After you have done that, that detailed coding of your file, what's right below that, it actually goes through and gives you what it would look like in a spreadsheet view. And you can see that this is a whole lot easier to read, that you're looking at the particular service that you're looking at is a major hip and knee joint repair or replacement. DRG 470, that is an MSDRG. So it's giving you a lot more detail, and this will be ultimately easier, at least they say, for people to review these files. I don't know that we will. Okay, these are machine readable files. These aren't people readable files, but this just gives you an idea as to what we're ultimately looking at. CMS has posted more detail on this. This is giving you an example from their GitHub site. And this particular one is, again, the CSV wide format. You can see the information related to the hospital name, et cetera, and to the best of its knowledge and belief, the hospital has included. That's all in the first line. You can see below that the address of the facility or addresses of the facility. And you can see that when total claim charges exceed $200,000 there is a additional payment that is identified there. You see on line 12 where it says treatment or observation room dash observation room, that is the particular item in the charge master. Revenue codes, well, they have 762 and separated by commas. That is a revenue code. It is outpatient. And then you're actually going through your various rates based upon your various payers. So again, a lot of information, a lot different than posting an Excel spreadsheet. And then again, for that same hospital, if you look at the actual spreadsheet view of that information, you are getting this type of information. You see the information related to local. That is essentially something that CMS has identified where there is a code that you are using, but it has not been described, or where you are providing more information, you would actually use local, and then there would be reference within your file for what do you mean by this. Key example that was raised in the questions that have been presented to CMS on this information is the issue of if you have a inpatient rehab unit or a inpatient rehab facility, they use CMGs, case mix groups. CMGs were not included in the list of codes that CMS has identified as what they want to be listed, but that is how you identify your services for inpatient rehab, and therefore that becomes a local code that you would be reporting. I mentioned that there has been a lot of discussion, and a lot of providers have said, how do I do this? I'm struggling, et cetera, and have asked CMS for a lot of questions. At CMS.gov/hospital price transparency, under the GitHub, you see this area right here called discussions. Well, if you go in and you click on discussions, you can sign up, and you will receive everybody's questions and CMS's answers, and you can go into other comments about a particular issue just by clicking on the email. You'll actually get an email on a regular basis that says, here's the question, here's the response. That might be a couple of days later, but CMS is fairly quick on responding to the questions that providers are raising. So let's kind of look at a few of these, because I think they provide a lot of insight into the complexity as well as some of the instruction from CMS on posting these files. Thought this one was very interesting. This individual said, I have a payer contract that identifies some services such as PTCA and coronary surgery by a list of ICD-10 codes only. That's one of those code types you can use, ICD-10. Coronary surgery's list is almost 4,000 codes long. None of these will have a standard gross charge amount, and the reimbursement is a case rate. So I'm curious how these should be handled on the report. It seems excessive to list all 4,000 lines individually on the report when the only difference would be the code. And it doesn't seem appropriate to list 4,000 code types on one line. How do we make this easy? Very complex. An individual, the same individual who posted the question then came back and said, when multiple code types are listed on the same row or line, does that mean and or? It sounds like you want an or. The same case rate charges applies to a large set of ICD-10. So do you list them all and put or between each one of them, or do you do and? My feeling is I agree with them that it seems like or is the appropriate one. My assumption has always been that when multiple codes are listed for the same row, that is an and of the codes. And if you want an or of the codes, you can always have multiple rows. So what are they asking for? CMS unfortunately responded to that offline. We never got the answer. But the way I'm looking at it is if it's a true range of codes, if they're truly 4,000 different codes, but they are sequential, then perhaps you can actually do post it as a range. Excuse me, grab some water here. But this is the kind of thing that people are asking. One of the questions that we get a lot relates to that estimated allowed amount, which is the average dollar amount that the hospital has historically received from a third-party payer for an item or service. This is the great insight from CMS. A couple of different points here. First of all, on the bottom, CMS, based on established industry practices, CMS recommends but does not require incorporating 1 year of historic reimbursement data in the development of the estimated allowed amount. Again, they recommend, they do not require. Same thing goes up at the top. In the interest of reducing burden to determine the best data source for calculating the estimated allowed amount, we decline to be prescriptive. However, we agree that using information from the 835 electronic remittance transaction, that would be a good way to meet this requirement. They are not saying that is the only way, the only thing you can do, but they did say that this is something that they think would be very useful. Again, in neither instance are they requiring the use of the 835 or a year of historic reimbursement, but they are recommending. So something else out of those GitHub discussions. This was one that I thought was very interesting in terms of the question that was asked. There's a mention of using a single indicator in the FAQs throughout the MRF files for the cells where the charges or rates are unavailable. For example, gross charges for surgery or MSDRGs for CMS does not want hospitals to average the charges. Could you expand on what would be the acceptable single indicator for these blank cells so that the MRF can run through validator without having any missing property errors? CMS goes on to say the minimum, maximum gross charge and discounted cash attributes are not required attributes if you have no applicable data to encode. Leaving these attributes blank should not produce errors when running an MRF through the online validator if you adhere to the technical specifications, including the conditional requirements found in the Price Transparency Data Hub repository. Again, they are saying if you don't have the information, you don't need to report the information. But I'm going to give you an issue in a minute. This was an individual who asked the question related to, if I don't have a standard charge, what do I do? And the answer said, if a hospital has not established any of the 5 standard charges for a hospital item or service, you're not required to include that item in the machine readable file. Please only include hospitals, items, and services for which you have established a standard charge. When the question was originally posted, I raised the issue of pharmacy because in many instances, you have not, your charge master itself does not include a dollar amount for some pharmaceutical items. They are actually priced at the time that they are provided to the patient based upon current pricing. CMS has essentially responded that at the point you are posting your file, what would be the charge for that information for that particular service? So it's going to be at a point in time. Recognize that you never put in a 0. You don't have any information to encode. But if you are posting it as of next Tuesday, what is your charge information as of next Tuesday? I might not have negotiated a rate for it, but I will have a charge. It might not be in my charge master per se, but pharmacy has that information. Another issue, because we ran into this in the past, in that patient rights advocate was very did not consider hospitals being compliant when they put NA in a field that was used a lot as it came about to reporting your self-pay rate or your discounted cash price. But they have now said very clearly, do not insert a value or any type of indicator such as NA if you do not have applicable data to include. If you want to have an explanation for your blanks, then you do that by adding generic notes or additional payer-specific notes. So that I thought I would let you have some insight as to that one. And then finally, in terms of the GitHub discussions, this one really looks into the idea of the algorithms. So as indicated in the final rule, based upon experience and enforcing the requirements of the regulation, we have learned that most commercial contracting methods result in a hospital's ability to identify and display as a dollar figure the payer-specific negotiated charges they have established with third-party payers. For example, a negotiated rate is established as a dollar amount for an item or service or a service package, or is established as a % discount off the gross charge, or a percentage of the Medicare rate, which can be translated and displayed in the hospital as a standard dollar amount. And then it goes on to discuss those case-by-case examples of algorithms. And when there is no standard amount available, this is where you post your algorithm, and then you go in and post that estimated allowed amount based upon your historical information. So I think whoever is working on this within your organization, keep an eye on what's being posted in the GitHub and the discussion that is going on. And you can clearly even follow based upon which particular format you are using. So that a couple of other one other thing in particular related to the posting of your information, and that is that CMS has now posted an online validator. I've given you the website for that validator. Once you believe that your file is ready to go, you can upload your machine readable file against the CMS template and data specifications, and you are going to get back whether or not there are errors. Now, there's a difference between errors and warnings. An error is there's a problem in your file and it's not going to be accepted. A warning is you don't have this information, but it's not required yet. For instance, if you do not have the modifiers or the drug units and measurements, that would be a warning because it's not required as of July 1, it's required as of January 1. Again, before you hit that affirmation of completeness and accuracy, I would make sure that someone has run your file against the validator and that someone internally has that information has been shared and that you can see that whoever is posting your site has run it against the validator and that there are no questions about that particular file. Now, in the few minutes we have left, I want to just talk about the enforcement changes and compliance. So let's take a look at the enforcement provisions that were modified as it relates to the to the new regulations. First of all, they are going to require you to acknowledge receipt of a warning notice. That only makes sense. If they sent you a notice, you're going to have to respond that you got it, because in many instances thus far, some of the providers who have been penalized said, I never got a warning notice. Well, now they are going to require you to acknowledge receipt. If you are being reviewed and your file is being reviewed by CMS, or their subcontractors, I have this feeling there will be some subcontractors, they could actually require you or request that you submit your actual payer contracts so that they can assess your compliance and your posting. Does your contract agree with what you have posted on that particular file? If you're a part of a hospital system, and one hospital perhaps or two within a system have not posted the files, but the others have, then they will probably work it at a system level as opposed to at the individual hospital level. And there will be a lot more publicity coming from CMS as it relates to enforcement activities. And let me show you what I mean by that. Well, before I do that, Penalties have not changed. There is a possibility that penalties could be adjusted in the outpatient rule that comes about. Well, I guess sometime in July we should see, or late June or early July, we should see the proposal. And there is a possibility that CMS will adjust the rates. They did not do so last year, so there is that concern that they will increase the penalties this year for noncompliance. But CMS just recently has posted this file when it said that they would be being more open about publicizing enforcement actions. They shortly after they issued the rule, they came out with this particular file. Gives you the clear indication that there are 200, it's not 284 hospitals that have been reviewed. It is 284 pages of hospitals that have been reviewed. And this gives you an idea, and I just printed it off very quickly from spelling perspective, alphabetically. You have the, let's take a look at the hospitals, and the initial hospital, Abbott Northwest in Minneapolis, Minnesota. They received a warning notice. They then received a request for a corrective action plan, and then they received closure once that corrective action plan was reviewed and put in place. But you can look up any hospital, you can look up your hospital, and just, hopefully you would know if you have an issue, but just recognize that CMS has made this information available where you can look up their perspective on compliance or non-compliance. Through the end of 2023, 913 warning notices were issued, 478 requests for corrective action plans. Closure notices were issued to 963 hospitals following the correction, and 473 of the hospitals reviewed met the requirements for compliance. There have been 14 civil monetary penalties that have been issued. 7 of those 14 are under review. The dollar amounts have ranged from about $57,000 to nearly $1 million, and those hospitals that have been penalized essentially run the gamut from critical access hospitals to academic medical centers. Again, on the issue of compliance, this was article from information from Health Affairs, where they were looking at the requirements for your file and their opinion as to compliance. They said that between September and November 22, CMS assessed websites of 600 randomly selected hospitals. This is the results, but here are some of the information in terms of what was actually assessed and what was identified. As an example, on the consumer-friendly display, they said that the list was made available free of charge, which it has to be. This is the way this assessment was done. Finally, from looking at transparency, there is Turquoise Health. A lot of people have looked up their hospital information on Turquoise Health. Turquoise has done an analysis of over 6,300 hospitals and 650 health systems, and well over $1 billion, a billion negotiated rates. Of those 6,300 hospitals, they say that 5,700 or 91% have posted the machine readable file. And then they go down further to actually look at the detail of the posting, not just have you posted the file, but does it look like it could be accurate? About 4,000 have DRG rates. Well, a critical access hospital isn't going to have a DRG rate. 5,134 have imaging rates, and where it says that they have BUCA rates, that is Blue Cross, United, Cigna, Aetna, and Humana. And as major payers, have the hospitals actually included that information as well? Do they have surgery rates? Do they have cash rates? Doesn't mean that you have to have cash rates, but 77% of the hospitals that have posted their files did post that their cash rates. This analysis and ongoing analysis will continue to be done as we move into the July effective date and then as of January next year. So Chris, I'd be glad to open to questions if you have anything in the queue.
Great. Thank you, Kathy. That's a lot of information to get in within an hour, and we always appreciate your appearances here at the Council webinar series. You know, I have a question here actually from my CEO, Stephen Love. There has been considerable press related to hospital non-compliance. Is it accurate?
Great question. And I guess I go back to my ending slides. There's been a lot of press, but if you go to, I guess I got to begin with the authority, and that is going to be CMS. CMS feels that the vast majority of hospitals are compliant with the current requirements, the requirements that were in place before these new ones. They do believe that the vast majority of hospitals are compliant. There have been reports issued by patient rights advocate related to their concerns related to non-compliance. They have been very aggressive in saying that the vast majority of hospitals are non-compliant. About once a quarter, they publish a report where they have reviewed a number of hospitals, and they list them and say that they are non-compliant, what they've done wrong. As an example, they have historically said that if you included NA on your file, that was non-compliant. Well, it was non-compliant up until till July of this year. But so it was an appropriate thing to do. The other issue that if you read the patient rights advocate reports, they stress the files are not patient friendly. They are not easily accessed and read by the patient or the consumer. CMS said when the rules were first issued, we do not expect this information to be used by patients as much as we expect it to be used by researchers, insurers, employers, and other providers looking at what their competition is getting. And to quote a great comment, or to share a great comment from Sean Stack with HFMA, National HFMA, the rule says machine readable, not human readable. So I think in terms of compliance, it's all in the eye of the beholder, and I'm going to trust CMS.
Okay, I have a final question here for you, Kathy. Who should be involved in certifying the completeness and accuracy of the file?
It's going to be a group of people. I would not allow, I wouldn't let the vendor say, I've done it and everything is right. You need to do some spot checking. You need to include compliance, because they're going to know what happens if you hit true and it's not true. RevCycle, Managed Care, who actually have negotiated the contracts, IT, that consultant that you might be using, CFO, others within your organization. I would even bring in perhaps in some department, well, whoever your CDM manager is, whoever is actually maintaining your charge master, they probably need to be a part of that discussion. And if you have individuals who in particular areas of your organization maintain the charge master, the inputs there, like for instance, if lab is doing their own charge updates or if pharmacy is doing their own charge updates, then I urge you to make sure that they're a part of this so they can spot check at least the rate information that has been posted for their part of the file.
Okay, we had another question come up here. So we have this data. What are hospitals and others doing with it?
Interesting. Because it's going to be, there'll be a lot more access, and I think it will be a lot easier to look at information moving forward. But hospitals have been doing price comparisons. Okay, Blue Cross is paying me this. What are they paying you? What are the rates across state lines? What are the differences in charges? And that is not, I don't know that we need to be focusing on the charge discrepancies. You can to some degree, but it's rates that I think you need to focus on. You can be using this information to actually, if you go to independent dispute resolution and you are arguing that the rate that has been quoted by the payer is not appropriate, if you have looked at the rates within your market that have been posted by that payer, that have been negotiated by that payer and others, with you and with others within your area, you can perhaps even dispute some of the proposals related to this is how much I think you should be paid if you're out of network, and actually show, but here's what you're paying the guy down the street. Look at like hospitals. And then I even think within types of hospitals, let's say children's hospitals, you could be doing a rate analysis to look at not only your charge rates, but also your negotiated rates with other like children's hospitals across the country, within your state, et cetera. What kind of rates are they being paid? So I think it does give providers a tool that they can use. And that's what it was intended for, more so than the consumer. Shoppable services were intended for the consumer.
Great. Thank you, Kathy. What a great presentation. And we're coming to the end of our webinar. I wanted to let all the attendees know that it was recorded. I'm going to post it online tomorrow and send a link to all registrants. I'll also send a copy of Kathy's presentation to everyone. Kathy, do you have a final comment?
I wish you great luck as you move forward with the posting of this information. If there are any questions that you might have about what I've presented, please don't hesitate to reach out to me. I'm at KREEP@PYAPC.com, and glad to have any questions.
Great. Thank you, Kathy. And I'll make sure that everyone receives your email address as well.
Thank you, Chris.
You're welcome. So that's the end of our webinar. We'd like to thank everyone for attending, and we are now ending the webinar. Thank you.